Mechanical traction. Mechanical traction is quite often used for what we call radiculopathies or pinched nerves. So a pinched nerve is where a bit of disc material pinches against a nerve, and this can create leg pain, can create back pain, and it can cause numbness, pins and needles, loss of muscle power. It tends to be quite uncomfortable. Now, age-old methodology, been around for 4,000 years, the Greeks used it, is mechanical traction. Basically, what we try to do with mechanical traction is just separate those vertebrae slightly. By separating those vertebrae slightly, we open up that space where the nerve comes out of, between the bones, and take a little bit of pressure off that disc. That allows for a little bit of the disc material to suction back into itself, but also allows blood to go back into this area and allows the swelling to go out of the area. And if you think about venous outflow and capillary outflow, somewhere between 5 and 30 millimeters of mercury, so quite low. The arterial inflow is obviously around the 80 millimeters of mercury to 120 depending on blood pressure. So the key here in the spine, in the low back, it's only a low load. We're talking about a load of between 8 and maybe 20 kilograms. At 8 kilograms, what we should see is a change in reflexes. They should start to normalize. A change in sensation, normalization of sensation, as well as a change in muscle power. They should normalize as well. The upper threshold though, like wherever it is, 14 or 15 or 20 kilos, all those things deteriorate again. So what must be happening? As the load becomes too strong, the muscles kick in and try to pull it back together. Whilst the load stays low, that's enough to create this reduction of pressure around the nerve and allow conduction of electricity along these nerve pathways down into the leg, which normalizes the muscle power in the leg, the sensation and the reflexes, and at the same time obviously should reduce pain. In the neck, the amount of dosage or loading should be obviously a lot less, and we're looking at between 0.5 kilograms up to 3.5 kilograms. And this is a lot less than what a lot of people have suggested in the past. But your clinical evidence are the changes, the normalizations in your signs and symptoms. Okay, this is just for mock purposes. What we do when someone is on traction, we obviously have the traction machine here and we have it on. We gradually increase the pull of the traction, and while we're doing that, or before we even start, we just have a look at the reflexes. See which reflexes are working, which ones aren't. We can look at the muscle power, so just hold that foot up there, just hold the foot up, hold it there, hold the big toe up, hold the big toe up, hold the foot in, and do that on the other side as well. And we can look at the skin sensations. So we can just ask the subject whether it feels the same going up the leg, whether it feels the same. And where it doesn't feel the same, or where the power is less, or where the reflexes are reduced, we use that to determine the dosage, basically the pull of the traction. It's that simple. Person lies here, usually the treatment time is between 10 and 15-20 minutes. At the end of the treatment session, they spend 5 minutes lying here, doing their deep abdominal muscle exercises. They gradually reset the muscles, meaning that while they're on traction, they're all relaxed. We remove muscle spasm. We have to replace that muscle spasm, that protective muscle spasm, with then normal synergistic muscle action, such as the abdominal muscles. And basically what we ask people to do is just to move their legs slowly up and down. On the other side as well. Gradually start doing some stomach muscle exercises where just purely drawing the stomach in, throwing the two bones together across this way. Breathing deeply through the sides to lift the pelvis up, pelvic floor up. And gradually increasing the muscle loading, the muscle movements to include lifting the whole leg up off the little couch here, getting them to push with one hand into their knee so they get more than the superficial muscles. So we've gone from the deep stabilizing muscles to the superficial ones. Then we get them to put each leg down onto the bed and do a little bit of bridging. Beforehand we've told the person how they get on and off the bed, obviously side rolling and sitting up, slide rolling. And once they're seated, we get them in the sitting position just to push the hand into the knee into the hand, and the other way around, which again activates the stomach muscles before we get them to stand up. And once they're up, get them to do a little bit of rocking from side to side to get that synergy of the erector spinae, the back muscles working. Plus we get them to lean on the wall, do a little bit of stomach muscle exercises by lifting the arm up. Lifting this arm up, the right arm, gets the left buttock working, stomach muscles, puts a stretch on the opposite calf. So that way we've reset, we've retuned the muscle synergy before they go and get dressed and leave the practice. Thank you.